Good evening, everybody. After the beautiful, wonderful this sand art and that reflecting the science, how it can progress to different levels and bring and carries knowledge to different parts of the country is really wonderful. And now this academic event, just going to present some few clinical issues. Most of the times it brings misguiding effect in the diagnosis and sometimes brings confusion in the diagnosis and also the treatment. And basically this presentation will deal with chest pain beyond MI. If only all chest pains were that simple to diagnose, and actually this is not the clinical situations. And whenever a patient comes to the OPD and tells the clinician that I'm having chest pain, and nowadays a lot of clinical issues, questions and examinations and the findings, and also the help of these different devices for treatment and the diagnosis of the particular disease comes into play. In the emergency department, whenever a patient comes with chest pain, the first initial idea to diagnose and to exclude the mitral infarctions. If you see a 40 to 45 years old patient and you just go through his clinical history and you try to find out the different risk factors, whether he is a smoker, whether he is a diabetic, whether he is hypertension, what is the level of the blood pressure at the time of admission into the emergency department. And also some of the clinical clues that related to the family history. At what age his father or maybe mother or first relatives actually suffer some myocardial infarction or other cardiac problem. It's very, very important, and also it helps in the diagnosis of or different causes of the chest pain. Whenever a patient comes, so these are some of the important etiologies that could be cardiac, could be pulmonary, could be GI, could be musculoskeletal. And majority of the patient, whenever it comes to the OPD, we see that the majority of the chest pain complained by the patients are due to musculoskeletal regions. So, and you will see that the most of the times patient will tell you that it is localized, particular point over the chest, it pains. And these are actually not cardiac, so mostly these are non-cardiac musculoskeletal pain. So there are some important clinical diagnoses where we can find the causes of the chest pain that is related to the musculoskeletal system. And later on we'll deal with these different types of diseases associated with musculoskeletal system. So this is a mnemonic actually related to the nerve suburine, and this might be helpful in the clinical practice. This is PAPA, P for pericarditis, and A for acute coronary syndrome, and could be pneumothorax. So you just auscultate over the chest, you will find nothing is there. There is silent cyst, and then whenever you put the percussion notes over the chest, and it can tell you that you are dealing with a case of pneumothorax. So it could be a cause of pulmonary embolism and aneurysm. Aneurysm, I mean that is aortic aneurysm, and that is mostly it is very deadly and it can kill life within seconds. These are the 6 differential diagnoses of chest pain. Actually, you cannot miss in clinical practice. That is acute coronary syndrome, pulmonary embolism, aortic dissection, esophageal rupture, pneumothorax, and pericarditis. There are some various causes of chest pain, like you can find a patient presenting with severe chest pain, basically in patient with severe pulmonary hypertension, myocarditis, and cardiac component also. Sometimes this is a rare actually syndrome, but actually most of the times you miss the diagnosis. This is Packard-Schuber syndrome. What happens? Particularly this syndrome is seen in female patient, and after severe psychological stress or somebody is very near or dear one actually dies, after that the patient actually develop, or there is severe psychological stress, and then patient will come to you with severe retrosternal chest pain, just mimicking acute coronary syndrome. And in the ECG, you will see that there is ST elevation, and the echocardiography will tell you that the apical part of the left ventricle is not moving, not contracting at all. So it is complete akinesia of that part, and there might be some ballooning effect of this apex also. That is why it is also named as apical ballooning syndrome. So this is a crisis situation where you might get sometime. You do the coronary angiogram, you will see that coronary anatomy is entirely normal, and there is no coronary artery stenosis. But the patient will behave like acute coronary syndrome. Even in the ECG also you might see ST elevation in the anterior ribs. So these are some rare occasions, but you might miss, and it might bring confusion in the diagnosis of acute coronary syndrome. Two important clinical situations presenting with musculoskeletal pain, and that can bring confusion in the diagnosis of acute coronary syndrome. Dibrugrh syndrome and costochondritis. How do you differentiate actually? How do you differentiate between these two syndromes? Dibrugrh syndrome, actually, whenever you palpate over the costochondral location, it will be tender, but also you will get swelling, and this part of swelling. So the differentiating point between Dibrugrh syndrome and the costochondritis is that you should get swelling in the first one, but not in costochondritis. And the costochondritis, you will see, you will feel, the patient will feel pain, and on palpation, there will be localized tenderness, but you should not get swelling. One other important musculoskeletal cause of chest pain is the Dibrugrh syndrome. So this is usually occupational, and after trauma or some kind of heavy exercise, the patient might develop Dibrugrh syndrome. At the Dibrugrh process, it will be tenderness, or sometimes it might get swelling also. So this is one of the differential diagnoses of Dibrugrh syndrome. This is the musculoskeletal cause of chest pain. The Dibrugrh syndrome, actually it is commonly named as floating rib or slipping rib or painful rib syndrome. So the lower part of the cyst, both sides, it may be isolated or maybe bilateral. The patient can have severe pain, and on palpation there will be tenderness. So this is because of malrotation of the ribs, or sometimes in very extreme cases, there might be rib dislocations. Actually, these are related to the floating rib. So that is why it is also named as floating rib syndrome, and patient can present with severe pain. How to approach? And first, the most important is that 80 to 90% of the diagnosis can be brought by clinical history and examination. And rest of the 5 to 10%, you might need some investigative procedures or some tools to diagnose. So the clinical history is very, very important, and the most important is that you have to exclude the myocardial infarction. So you can do ECG very quickly, and then in those cases there is some doubt of diagnosis of acute this coronary artery disease can present with some stable angina. So you can go for the stress test, but never do a stress test in a patient with acute coronary syndrome. Or if there is much doubt about the diagnosis, so you can go for the coronary angiogram and then to rule out acute coronary syndrome in some of the cases. Chest X-ray is very, very important, and it can rule out the pneumothorax very quickly. So if there is a history of trauma, chest trauma, or it may be spontaneous also, and also it is effectively can rule out aortic dissection. You just look into the mediastinum. If there is a mediastinal widening, and then you might be dealing with a case of aortic dissection or aortic aneurysm. And clinically, it is very important. You check the blood pressure, you check the pulse. There might be differences or in the pulse in the different limbs, or the blood pressure may be different in upper limb or lower limbs depending upon the segment of the aorta involved by the dissection. So this is one flow chart, how to diagnose different causes of chest pain. Cardiac markers are very, very important. You do CKMB and troponin I. Nowadays, we use a lot of, in cases of chest pain, where the risk factors are quite evident, to bring or enroll the diagnosis of myocardial infarction. You can do high sensitivity troponin I. Here the sensitivity is very high in case of high sensitivity troponin I, but it is less specific. You can find very high level of SS tropi, high sensitivity troponin I level, even the patient is not suffering acute coronary syndrome, because this is actually a marker of myocardial injury, is high sensitivity troponin I. So in any case of accelerated hypertension or heart failure also, you might get very high level of high sensitivity troponin. So actually high sensitivity troponin, actually it actually detects troponin with a very high sensitive assay. That's why it is called high sensitivity troponin I. And so you have to rule out acute coronary syndrome, that is very important. And then pulmonary embolism. If the clinical history giving you some clues that the prolonged immobilization, post-surgery condition, particularly the orthopedic surgery, or the patient is young, there is history of arthralgia, or there is a possibility that you are feeling a case of connective tissue disease or SLE. So the patient can develop deep vein thrombosis, and you can elicit Homan sign also, so the possibility of deep vein thrombosis. And in those situations, is very likelihood that the patient might develop pulmonary embolism if the patient is presenting with severe chest pain. So the hemodynamic parameters are also very important. You have to see the pulse. So usually you will get sinus tachycardia, and some of the ECG findings are also very helpful to know the possibility of pulmonary embolism. D-dimer assay is important. So it can rule in the diagnosis of pulmonary embolism. Aortic dissection, the possibility is very important. The history of smoking is there, or the patient is a case of hypertension, uncontrolled hypertension. And in those situations, there is a possibility of aortic aneurysm or aortic dissection. So urgent CT angiography can bring the diagnosis of aortic dissection or aortic aneurysm. Echocardiography is very, very helpful. If you do echocardiography, if you find pericardial effusion and aortic regurgitations, so probably you are dealing with a case of aortic aneurysm, aortic dissection that involves the ascending aorta. Clinical findings and laboratory parameters are not fitting. So you probably may be dealing with a case of musculoskeletal symptom, non-cardiac, or maybe musculoskeletal syndrome related to chest pain. So there are variety causes. Multi-specialty approach sometimes needed for diagnosis of certain cases of acute chest pain. Probably you might be dealing with a case of esophageal spasm, diffuse esophageal spasm. So you need sometimes the need of a gastroenterologist to come into the picture for the diagnosis of diffuse esophageal spasm. You need to go for endoscopy to check for the spasm, or you need to do 24 hours testing, PS testing, or manometry testing. So these are some of the very specific parameters or testing you can use for the diagnosis of non-cardiac chest pain. With severe retrosternal chest pain, and it will definitely put you in trouble. You might think that the patient is suffering from acute coronary syndrome. So it is a diffuse esophageal motor dysfunction. So patient actually comes in severe spasm, and actually it is relieved by nitroglycerin. So you put nitroglycerin tablet and the pain relieved. So probably you are dealing with a case of diffuse esophageal spasm. So that is why. So we have a tendency to give solvitrate retrospectively to know that whether the patient is having angina or not. Sometimes it might be misleading. And panic disorder. In clinical practice, you will see people with panic disorders, common panic disorders. There is the patients are usually very unstable, tachycardia, diaphoresis you will see, and tremor you will see because of the high adrenergic drive. And actually, these are the people who are suffering from severe panic disorders. And hopefully, the exclusion of the myocardial infarction are not very difficult in those group of patients because you have a lot of batteries of tests, ECG, echocardiography, and also biomarkers, and also the importantly the clinical clues. If you are dealing with a case of acute coronary syndrome, you have to give the aspirin or clopidogrel or both, solvitrate, nitroglycerin, and morphine may be needed sometimes in those cases. So your diagnosis should be pinpointed in those situations. If you are dealing with a case of aortic dissection, you have to immediately refer to a patient with a highly sophisticated center where the aortic dissection can be treated. And unfortunately, you cannot treat most of those patients because they die. If you are dealing with a case of aortic aneurysm, even in the X-ray also sometimes the patient having severe retrosternal chest pain, and there may be some. You do the SS X-ray, you see that there is huge mediastinal enlargement. So probably you are dealing with a case of aortic aneurysm. So these are the diagnoses you cannot exactly miss because missing those diagnoses can take away the life of the patient instantly. Pericarditis is one of the situations. So it is not very difficult to diagnose acute pericarditis, and you might miss the pericardial valve, particularly in the initial situation, and later on the pericardial diffusion started in, and then you might miss pericardial valve also because both the layers of the pericardium get separated. In the ECG, it is very helpful to diagnose acute pericarditis, and you have to differentiate it from acute myocardial infarction, different patterns of the ST elevations, and the evolutions of the ST resolutions is also very important to diagnose acute pericarditis. This is one of the, for the general practitioner, to know whether you are dealing with a case of cardiac disease, particularly cardiovascular disease or non-cardiovascular disease. So if the age of the patient is more than 55 years or even over 65 years of age, and known vascular disease, previous history of myocardial infarction or peripheral artery disease, and symptoms are reduced by exercise. The symptoms are exertional mostly, angina. So and it is diffuse all over the chest, cannot be exactly localized, and those are the situations. Actually, you are dealing with a case of acute coronary syndrome, and the family history is also very important. So there are some scores given, and the likelihood of coronary heart disease is very high if the score is approximately 4 to 5. So this is a very simple scoring system designed for the general practitioner so that they cannot miss acute coronary syndrome. So this is a very simple slide where all the symptoms, location of the pain, and the quality of the pain, duration, aggravating and relieving factors, sign and the symptoms are separated and segregated, and gives clues for the diagnosis of different causes of chest pain. In myocardial infarction, we already talk about, and the pneumothorax, we do clinical examination and the X-ray is very helpful, so it's not very difficult to diagnose pneumothorax. Pericarditis and pericardial tamponade are not very difficult, so you just auscultate. The heart sounds are very muffled, you might get pulsus paradoxus also in the clinical examination. And those are the clinical clues that can help you for diagnosis of pericardial component. Clinical diagnosis is important. Apart from this, the gold standard for diagnosis of pulmonary embolism is CT coronary angiography. So the CT coronary angiography can exactly diagnose what are the levels of pulmonary arteries involved, whether it is distal or proximal, and based on that different treatment strategies can be planned. Aortic dissections accordingly the same. You need a CT angio or MR angio to know exactly the site of the aortic dissection and the extension also, and accordingly we can plan the strategy of the treatment. But initially to diagnose, you have to rely on the clinical clues and also some of the investigation like X-ray and the echocardiogram. So the points to remember, we should not focus towards the acute coronary syndrome. That is why these slides are brought in, and the main target of these slides is that we should not concentrate most of the times to diagnose acute coronary syndrome. But being a cardiologist, the problem is that we cannot miss acute coronary syndrome. Sometimes we overtreat. And the patient presented to you with retrosternal chest pain. So sometimes we give aspirin, clopidogrel, or atorvastatin also. So that sometimes we overtreat, so that we should not miss diagnosis of acute coronary syndrome. And stable angina pectoris, that is stable ischemic heart disease, actually responsible for 10% of the chest pain episode in patient presenting with chest pain, primarily to the healthcare physician. And among them, the unstable angina and MI incidence is 1.5% of the patients. And approximately 60% of the chest pain diagnoses are not organic. So these are non-organic causes, mostly psychosomatic. This is one of the case. This is 60-year-old man with a history of diabetes and hypertension. These are two very important risk factors. And presenting to the emergency department with a one-day history of retrosternal chest pain. And his chest pain began while he had been resting and continued to be worsened over the next few hours. And it described his very sharp pain and with radiation to the right shoulder and neck. And the pain worsened when he is lying down and with any deep breathing, but it is relieved by bending forward, and he denies having any shortness of breath or palpitation. Do you have any clues what kind of disease you are dealing with? Breath, and he denies palpitation. Patient has history of hypertension, diabetes, so you might be confused that the patient probably is suffering from acute coronary syndrome. But if you look into the clinical history, there is no shortness of breath and no palpitation, and this pain doesn't look like angina. And it looks like some kind of musculoskeletal or pleuritic kind of chest pain, because it changes during this change in the position of the patient. But there is a significant history of cigarette smoking and also coronary artery disease in the family. But still, the description of the pain denies angina. If you go to the vitals, the blood pulse rate is regular, blood pressure is 130/80, and make examination, there is no sign of jugular venous rise of ZP, and the heart sounds are absolutely normal, and there is no edema in the legs, and peripheral pulses are normal and symmetric. Laboratory test, nothing impressive, but there is slight increase in the elevated creatinine kinase. So, this is the ECG of the patient. What have you found? So there is ST elevations, obvious, and can you tell me the morphology of the characteristic pattern of the ST elevations? whether it is concave, whether it is convex. Is there any relation of ST segment elevation compared to the leaf plates and the sess plates? And the pattern of the ST elevation is concavity upward, and it is kind of sustained. So probably you are dealing with a case of pericarditis. In pericarditis, one important finding is that you should also focus to the PR segment here. Differential diagnosis. So answer is pericarditis. Why? So what is the actually what do you find in the ECG that tells you that you are dealing with a case of pericarditis? So this 12-week disease in patient with acute pericarditis classically shows widespread concavity upward ST segment elevation associated with PR segment depression and PR segment elevation in late AVI. The ECG abnormalities, and it actually follows a certain evolving pattern in terms of the STP changes in the ECG. So in the stage 1, you will get diffuse ST segment elevation and PR segment depression, and stage 2, it is normalization of the ST and PR segments and flattening of the T wave, and in stage 3 you will get widespread trivial inversions, and this stage 4 there will be normalization of the ECG changes. Acute pericarditis. So treatment is not very difficult. There are different causes of acute pericarditis. It could be viral, it could be non-infective, it could be bacterial. Mostly we see the viral causes of acute pericarditis, and it could be post radiation. It could be following myocardial infarction also. There are a lot of causes of acute pericarditis, and depending on the different causes of pericarditis, we treat the patient accordingly. So we need to give this ibuprofen or indomethacin or colchicine works sometimes, and sometimes we need to give steroid therapy also. These are all basically meant for symptomatic relief. This is another case. This is 42-year-old man presenting with chest pain, and there is a dull anterior precordial and retrosternal chest pain that begin acutely with a tearing sensation. So this is very important. If the patient tells you that it is very severe pain at the onset, and then it's like a tearing, so it tear off everything. So it lasts for 2 days, and he states that during this period he has been unable to get comfortable, and the intensity of the pain increases during inspiration and with body movement. And the patient denies any symptoms of recent viral infection and has received no recent vaccination also. History from the past: no hypertension or coronary artery disease, no cardiac surgery. Because sometimes following cardiac surgery, we see this kind of clinical picture. No diabetes mellitus or no history of dyslipidemia, no family history of cardiovascular disease, and there is no over-the-counter or intake of any herbal medications. Looking into the parameters and hemodynamics, blood pressure is high, 160 systolic and 102 diastolic, and there is tachycardia. And the clinical examination, very important in this situation, an early diastolic murmur of air. In this patient, the cardiac enzyme may be positive after a few hours. X-ray is very important. What have you found in the X-ray? If you look into the mediastinum, this is definite enlargement of the mediastinum. So it straightforward gives clinical clue that you probably dealing with a case of aortic dissection, because in the clinical examination we have found aortic regurgitations. So the probable diagnosis Acute pericarditis, ascending aorta aortic dissection, acute myocardial infarction, and hyperkalemia. In hyperkalemia also sometimes you may, in hyperkalemia, severe hyperkalemia, you might get hyperacute T wave. So this is clear-cut diagnosis of aortic dissection, and echocardiography is very helpful. You can detect aortic regurgitation, pericardial effusion, and sometimes you might get a flap that is dancing inside the lumen of the aorta in the ascending aorta, and there is separation of the flows. So that indicates actually aortic dissection, and CT scan and the MR angiogram will clearly tell the type of the aortic dissection you are dealing with. So this history of sudden tearing sensation at the onset of the symptoms is a classic presentation for an acute aortic dissection, and it would be atypical for a patient with acute myocardial infarction. Acute myocardial infarction usually sustains and it increases the severity over the time. And patient with acute myocardial infarction may have a preceding history of exertional angina. Sometimes you may not get it, and they may have substance, pressure, and heaviness, and that is not positional. In addition, the patient physical examination gave important clues to the diagnosis. The patient was profoundly hypertensive, which is also itself a non-specific finding. Already patient had equal blood pressure in both arms, but sometimes you may get unequal blood pressure and unequal pulse volumes. This is the types of the aortic dissection, not going in details. There are two classifications, Stanford and the DKK, based on the level of aortic dissection and its extension. These are certain, sometimes some causes of non-cardiac chest pain, musculoskeletal already been described, pulmonary and severe pulmonary hypertension because of the RV ischemia. You might get angina-like symptoms. This is because of the right ventricular ischemia. Because the soldiers actually they pretend that they are having some kind of cardiac problem, and so that because of the long years they stay in the wards and they don't they are not allowed to go home. That's why they just pretend that they are having severe pain, and then that brings confusion. So this is actually the Acosta syndrome, and patient used to have retrosternal chest pain. Actually they pretend to have it, actually not. These are certain causes of non-cardiac chest pain, cervical disc disease, costochondritis, and herpes zoster before the appearance of the rest. Sometimes it's very difficult to diagnose. And pleuritis and pulmonary embolism is very important. Tension pneumothorax is life-threatening. You have to treat very early. And some of these psychosomatic disorder can bring confusion. Biliary, peptic, and pancreatitis disorder can lead to chest pain, and the reflux disease, esophageal disease are very, very important as differential diagnosis. Reflux, gastroesophageal reflux, esophageal spasm, hypersensitivity, and echalalia cardia is another differential diagnosis. Costochondritis been already described. How you can differentiate from AG syndrome. AG syndrome actually it is described by the German scientist Alexander Page in long years back, 1921. So gastroenterologist needs to come in for diagnosis of some specific causes of gastroesophageal reflux disease or disease of esophageal origin. You need some devices also to know the pH, or esophageal manometry is another important tool. Acute chest pain. So you will get hypertension, these are variety type of chest pain, substernal location. You should always examine the legs whether there is any edema or not, or you try to elicit the presence of any deep vein thrombosis, and prolonged immobilization and post-orthopedic surgery condition are very, very important. And echocardiography is and also ECG. And in ECG you will see We commonly tell about S1, Q3, T3 syndrome, but only 10% of the patient in the ECG we get this syndrome. And the most important finding in ECG is sinus tachycardia. And you will get the early strain. In the right sided lead, you will get ST depression, Q wave inversion. So this is called early strain. And sometimes you may get right bundle branch block and right axis deviation also. And these are some of the clues for diagnosis of pulmonary embolism. Echocardiography is very helpful. You see the right atrium and right ventricle. This will be grossly dilated. You might get tricuspid deviation velocity. And sometimes, if you are lucky enough, you might see the thrombus in transit. So you just, but you should not miss the thrombus. Sometimes you miss the thrombus in the inferior vena cava. So the junction between the inferior vena cava and the right atrium, you should always look for. If there, you may get thrombus in transit. This is one echocardiographic snapshot. Right side, you will see that RARD is dilated. So to conclude, chest pain is the most common problem presenting in an acute care setting, and it is caused by both cardiac and non-cardiac etiologies. The life-threatening causes of chest pain must be quickly differentiated. That we already mentioned that the 6 causes of acute chest pain, which may be life-threatening. A step-wise differential diagnosis should be carried out to rule out different possibilities for chest pain. History and physical examination remain in frontline on evaluation of acute chest pain. General practitioners should be helped to make decision about the referred patient as well as managing those referred back from the cardiologist after diagnosis of non-cardiac chest pain. Risk for evaluation, like for diseases like Marburg heart score, is also important, may be helpful in some of the situation. Invasive investigation should be reduced by cardiologists and should be used appropriately. We should not use the angiography in all the cases, and the clinical examination can rule out at least 70 to 80% of the patients where the diagnosis is appropriate, and we should use the angiography in the appropriate condition where you should get at least 95% diagnosis of acute coronary syndrome by doing an angiogram. So unnecessary investigation should be avoided. Thank you. I'd like to mention my teacher, actually, is a very eminent teacher, Professor Hemchandra Padre sir is here. So I just want him to say a few words. So please come.